All right, we're going to see if we can finish up this PowerPoint real quick. So we're on to the slide about magnesium sulfate. So magnesium sulfate is the most effective medication to prevent and treat eclamptic seizures. The method of action, like I said before, magnesium sulfate is not given to decrease the blood pressures necessarily, but what it does is relax the skeletal muscles through direct action on the CNS, raising the seizure threshold. So we're trying to decrease the seizures with the magnesium sulfate. It is given IV, it is controlled on a pump and monitored very closely. It is excreted through the kidneys. We have to monitor vitals every 15 to 30 minutes, do hourly A's and O's, hourly DTRs and clonus checks, assess for increasing edema, and auscultate lung fields for signs of fluid and crackles. They can get fluid volume overload quickly with mag sulfate here. All right, monitoring mag levels. Our therapeutic level is between 4 and 8 milligrams per deciliter. Toxicity would be 9 milligrams per deciliter or greater. So generally the RN administers mag sulfate, but the LPN may assist with monitoring of the client. So you are usually not going to be the one administering the mag sulfate, but you may be assisting as far as monitoring DTRs and vitals and auscultating lung sounds and things like that. They're all critical steps in magnesium sulfate administration. All right, so signs of magnesium toxicity are going to be absent deep tendon reflexes. So we check deep tendon reflexes, we hit the knee there, and if there's no reflex, we've got some problems. As respirations of less than 14 per minute, urinary output less than 30 milliliters per hour, and the antidote for mag toxicity is going to be calcium gluconate, which is given IV push. All right, now mag will also have these same effects on the infant. So infants born to moms who are on mag, for who are eclamptic or severely preeclamptic, the babies that are born will have be very flaccid, very relaxed muscle tone. They don't cry real vigorously. They're just kind of laying there. So you have to work with them a little bit more. All right, so what to do in the event of an eclamptic seizure. All these things here, placing the woman on her side, provide oxygen, establish an IV, evaluate vital signs and fetal heart tones, administer mag sulfate if it's not already infusing, watch for signs of precipitate birth. That means we're having the delivery before we expect it. Section PRN, if it's safe to do so, notify the physician, and client and family support. Now after delivery, we're monitoring for seizures, which can occur for up to 48 hours post-delivery. So typically these patients will actually stay over in labor hall, and in my area anyway, and will stay over in labor hall for 24 to 48 hours of status post-magnesium. So they will end the magnesium and then they will stay longer for more close monitoring. Then we need to assess for hemorrhage as well, because remember that what it does is relax the muscles so the uterus does not contract as well. We need to monitor platelet counts and signs of bleeding. If the infant's in the NICU, we need to provide pictures, and so much we can do now with all the technology, but making sure that the mom doesn't feel left out just because she can't go to visit the infant right away. All right, thromboembolic disease. These are physiologic changes in pregnancy related to venous stasis and high coagulation. State of blood increases the risk of superficial thrombophlebitis, deep vein thrombosis or DVTs, and pulmonary embolism. All right, venous stasis is evidenced by increased blood volume, the vena cava compression by the gravid uterus. Hopefully you know what gravid and uterus mean. So the combination there of a gravid uterus means a pregnant patient, a uterus with a baby in it. Lower extremity edema and worsening of varicose veins. So our risk factors are those women who have used oral contraceptives prior to pregnancy, and that's labeled right there on oral contraceptives. Those who have jobs where they sit for long periods of time, older women, and obesity. All right, moving quickly along, iron deficiency anemia. Difficult for women to replace iron losses by nutrition alone. So it is common that we need to have supplements to supplement this iron deficiency in pregnant patients. All right, pregnant patients also use antacids quite frequently, which decreases dietary iron absorption and predisposes women to anemia. So there's their definition of anemia: hemoglobin less than 10 and a crit below 30. Now, women with anemia will often feel fatigued, so it's kind of hard to tell. They all feel fatigued anyway, but it's an excessive fatigue. They're at risk for infection and preterm delivery as well. So daily iron supplements are recommended. And vitamin C and zinc enhance the absorption of iron. Okay, those are things that are important to know for boards, really. That vitamin C and zinc, there's so many things that we have to be sure that we don't take with medications. But with iron, what we need to know is that we do need to take vitamin C and zinc will enhance absorption, but calcium supplements, Tums and things like that are going to decrease our absorption of iron. All right, hyperemesis gravidarum. This is severe nausea and vomiting prior to the 20th week of pregnancy. It can cause severe dehydration and weight loss. Contributing factors are endocrine imbalances, so hormones. That's what happens because their hormones are all out of whack. These women are vomiting profusely to the point of dehydration and severe weight loss. They have very low gastric motility, and the fetus can be at risk for IUGR if it goes on too long. So when I had severe nausea and vomiting with both pregnancies all the way through, but never got to the point, well, I shouldn't say that. I hydrated myself. I IV hydrated myself a few times at work, but yeah, it should never really be done. But around my 20-week visit with the twins, they were getting very concerned because I still was not gaining weight. And here I was pregnant with twins and still not gaining any weight because I was still so sick. Obviously that resolved. And I did finally start putting on some weight and things moved along with the pregnancy. Do you have a higher incidence in your first pregnancy? So I did vomit frequently with the first pregnancy, multiple gestation pregnancy. So although that was my second pregnancy, it was a multiple gestation, molar pregnancies, and a history of hyperemesis. Also, if the patient has pancreatitis, hepatitis, and thyroid disease, these need to be ruled out with this severe hyperemesis. So clinical presentation, everything we've already kind of talked about here, but read through those. Treatment usually requires hospitalization, IV solutions with dextrose, potassium to the IV fluid to correct the hypokalemia that usually occurs, multivitamins and minerals to rebalance out any imbalances from electrolyte losses and everything. NPO until the vomiting stops, then liquids, same as with the regular normal diet, your brat diet. Now they will a lot of times get around the clock antiemetics because we don't want to wait until they're vomiting to make them stop vomiting. We want to try to prevent the vomiting. Recording strict I's and O's. These patients will be on what we call strict I's and O's. Daily weights, monitoring lab values, and monitoring the fetal heart rate Q shift. All right, finally, quickly here, is gestational diabetes. So gestational diabetes is obviously diabetes intolerance with the onset during pregnancy. So these patients had no signs of diabetes prior to pregnancy. They get pregnant. They do their 1 hour glucola testing, and it's determined that they have elevated blood sugar. So they'll do a 3 hour glucola testing, glucose tolerance test, a GTT, and determine that they have diabetes, gestational diabetes. Stress of the pregnancy can put too much strain on the pancreas, so they can't keep up with the extra demand. Develops after the first trimester of pregnancy and should return to normal by 6 weeks postpartum. So again, it's something that only occurs, it only develops during pregnancy and it'll go away after pregnancy. Diagnosis is important because of the risk to the infant. Glycosuria are the symptoms, and they may exhibit the classic signs as well. Now, diagnosis usually is done at 24 to 28 weeks. That's when they do this 1 hour glucose tolerance test that I was telling you about. Treatment is going to be diet controlled. Most gestational diabetics can be diet controlled with a low carb diet. Glucose monitoring, fasting, and postprandial. So we do fasting 2 hours postprandial, and bedtime is how we often do it in the hospital. So the goal is to have 60 milligrams per deciliter fasting and 120 milligrams 1 to 2 hours after meals, postprandial. All right, labor may be induced between 38 and 40 weeks if needed. These gestational diabetic babies are at much higher risk of being large for gestational age, macrosomia, large babies. NSTs and serial ultrasounds are performed to monitor placental perfusion. The baby's size is very important, and the fetal well-being. Now, when you go to the NICU, you usually see all these little tiny babies. Outside of that, you're going to see these really big babies, oftentimes, which are these gestational diabetic babies. So they are born, delivered, have a very hard time maintaining their blood sugars, and are required to go to the NICU to get IV glucose as well to get their blood sugars under control. All right, 10 to 15% will require insulin. 35 to 50% will develop type 2 diabetes later on in life. Okay, so not everyone will, but some of them will. Infants of gestational diabetic or diabetic mothers tend to be larger due to the increased sugars crossing the placenta, so it's referred to as fetal macrosomia. So that's what I was telling you about. There's some information, figure 5.7 on page 97 about this, but I'll tell you right now, my daughter's boyfriend said he was like a 10-pound baby, 10 or 11-pound baby, so immediately I said, your mother must have had gestational diabetes. That is a huge baby. So any of those really big babies like that, that's kind of the first thing you think of oftentimes. All right, infections. We've got urinary tract infections. Your increased risk when you are pregnant. The gravid uterus causes that urinary stasis. Signs and symptoms, which you all should already know, but be sure you look over it. We've also got rubella, which is highly contagious, and I think I've told you guys about this as well. I know I talked about it earlier at some point, where you're going to vaccinate the woman prior to leaving the hospital because the vaccine is contraindicated in pregnancy because it is a live vaccine. All right, you also want to know about the torch infections, so those toxoplasmosis, rubella, cytomegalovirus, herpes simplex virus. So that's on page 103 in your book. All right, so that was continuing on a little bit more with rubella there. You must be warned not to become pregnant within the next 3 months after receiving the rubella vaccine, again, because it is a live virus. Toxoplasmosis is another one. They're asymptomatic of the infection, but it's contracted through poorly cooked meat and cat feces. That's what they tell pregnant women not to change the litter boxes. All right, so look over the prevention and the risk to the fetus there. Herpes, associated with increased risk of miscarriage and preterm labor, is highly, highly contagious to the newborn. Therefore, if there are genital lesions at the time, it is required that the mother have a C-section. If there are any active genital lesions, she must have a C-section. She cannot deliver vaginally, or the infant will contract the herpes and it can kill them. All right, they must not come into contact. Very, very dangerous. Then we've got cytomegalovirus quickly here. So I'm probably not going to get through this. And then we've got GBS. So be sure that you read over all the GBS group beta strep information as well. Be sure you scan over all, not scan it, but read it all really well. And take special note here, the fact that the infant can be infected by group beta strep as well, but this infant can still be delivered vaginally. The mother just needs to have some antibiotics during labor. So usually they're getting 1 or 2 doses of penicillin during labor, but this infant can still be delivered vaginally. Unlike with the herpes, she cannot deliver vaginally. All right, and then let's see, we've got, be sure you read over all this GBS information. That's really important. Then we've got substance abuse, so that includes your illegal drugs, tobacco, and alcohol. Newborn is at greatest risk during the first trimester, however, it can be damaging throughout the entire pregnancy. Okay. Nurses need to be alert to the physical signs and attentive in collecting patient history. I think I've told you before, it's amazing what patients will tell you if you just ask the right way. They will give you a lot of information. Okay, so I know I went through that super, super quickly. Be sure you read over all of this information, look it up in the book. Table, see, I don't have a table for GBS, I don't think, but there is information in your book on GBS. Be sure you look at that. The torch information was on page 103, and page 109 has